Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free.
Welcome to this Australian Prescriber Podcast. I'm Dr. Justin Coleman, a GP on the Tiwi Islands north of Darwin, and I'm editor of the Diabetes Management Journal. I'm delighted to be speaking today with Ralph Ordem, a Melbourne GP and Clinical Honorary Associate Professor at the Department of General Practice, University of Melbourne. Welcome, Ralph.
Thank you, Justin, for allowing me to talk about a subject that's so close to my heart.
It's lovely to have you. We're talking today, of course, about the latest version of therapeutic guidelines for diabetes, which you were heavily involved in as a contributor on their expert group updating the guidelines. And being a cutting-edge type of guy, Ralph, I wanted to specifically focus today on what's new in this edition. So things that GPs and other health professionals might not have seen before in the book and how it keeps up with the rapid advances these days in diabetic management. So let's start with hyperglycemia, which I guess in one way is where all diabetes starts. The new section on management of first presentation with hyperglycemia. And I guess the urgency of this very much depends on the context. Is it an older person whose sugars have been slowly creeping northward for months or years, or is it an unexpected finding in a sick child or adolescent?
Justin, look, the two areas that I think that were really stressed was firstly reiterating just how important it is to capture children and adolescents with hyperglycemia. So at the first presentation, basically diabetes or hyperglycemia has to be considered a medical emergency. There's a lot of evidence to suggest that children who present with their first episode of diabetes or hyperglycemia aren't sent to the emergency department immediately. There seems to be a delay while people confirm maybe what a finger prick test is by doing a blood test. What we're really strongly iterating here is that in any child or adolescent with hyperglycemia should be sent directly to the emergency department. It is a medical emergency. And we know that 50% of children with diabetes will actually end up being admitted in diabetic ketoacidosis. Half of them will have been seen by a GP within the preceding 5 days.
Okay, so I guess there we need a high index of suspicion for the sick child, and also once we do see that high sugar, it's all hands on deck immediately.
Yes, we often say that you can't use finger prick to diagnose diabetes, but in children, if you do a finger prick and the sugar is elevated, they need to go to hospital.
There's also probably the rarer but still equally important complication of diabetic ketoacidosis, particularly I think with some of the SGLT2 inhibitors. We are likely to see a bit of an increase in diabetic ketoacidosis when people get sick or perhaps undergo surgery or have some other major stress to their physiology.
Yes, throughout the booklet, there is a specific mention around the fact that SGLT2 inhibitors can, increase the risk of diabetic ketoacidosis. And it can also be a little bit harder to diagnose them as having diabetic ketoacidosis because their sugar levels or glucose levels may not, in fact, be that high. In a person with type 2 diabetes who is unwell, who is on an SGLT2 inhibitor, do think, could this be ketoacidosis? And yes, they need to then do a finger prick looking specifically at the ketones. If that's unavailable, then if they're vomiting or unwell, really they should be sent to the emergency department. And the other thing that was specifically mentioned around SGLT2s, we're all very familiar about stopping metformin prior to major surgery or through someone's going to have IV contrast medium. But we've also iterated that for people going to surgery or who are unwell who are on an SGLT2 to consider stopping, and certainly before surgery, stop it at least a day beforehand.
Thank you. Let's slide down the sugar pole now, if we could, from hyperglycemia up the top and have a look where we want glucose to sit, the sweet spot, I guess we could call it. And you have updated information in the new therapeutic guidelines about ideal Hba1c targets for the individual. How important is it to try to individualize these targets depending on the population you're dealing with and the individual circumstances?
Everyone's come on board now with the personalisation of medicine. And I think this is really key because the one size does not fit everyone. And so, yes, we have a general target, but I think when we look at our patients, it's actually really critical to see what is a desirable target for them, whether they can achieve it, and whether it's possible to achieve it with, our current medications that we've got available to us. Talking to a patient about where they should be, I think, is really key, because a lot of people don't know what their target should be. And then I think we talk about whether they're at target or not at target, rather than, you're failing, because I think language is also really important when we talk about individualizing targets. For people who are elderly, who are unwell, or may have other comorbidities where we're not expecting them to live a long time, they will not get benefits from having really tight control of their glucose. And so we tend to be a little bit more relaxed in that situation. And I think that's important because we do want to avoid hypoglycemia, and management of A1C is about long-term complications, not the short-term complications.
I think that's a very important point, and it is refreshing to see guidelines also look at not just at what medications we should be using, but also the potential harms of those medications. And I know therapeutic guidelines always does that very consistently. Ralph, despite Hba1c targets being important, there does seem to be increasing recognition that much of the mortality and morbidity of people with diabetes tends to be cardiovascular related. And the primary treatment of this starts with lifestyle modifications, so your diet and your exercise, followed by cardiovascular preventative agents such as antihypertensives. And this actually does more good than fine-tuning that last 0.5% on their Hba1c.
You're correct. I mean, most people with diabetes will die of heart disease. Of course, we see that far more early and far more common in people with type 2 diabetes. And so, treating the risk factors for heart disease is really key in terms of keeping our patients well.
Look, of course, Ralph, where would therapeutic guidelines be without a comprehensive discussion of all the newer agents out there? And it is a rapidly changing field over the last 4 or 5 years. So I was glad to see there a table comparing all the different classes of medications. I think that's one of the most commonly used aspects of the book from a GP's point of view these days.
Yeah, and we're going to see more and more come along, as well as more and more within the same classes. So it's getting a pretty busy field out there. One of the participants in our expert reference group came up with this nice little sort of flow chart of what to use and when. And I think that's really good, because it actually at the very top says, if you've got someone with type 2 diabetes who's symptomatic or really high blood glucose, start insulin. Get in there early, get control, then you can sort out what you're going to do in the long run. But it also says if you're starting with a very high A1C, actually start off with dual therapy rather than just metformin and wait to see what happens. So, that's a little bit different. When it comes to adding in a second line medication, it does talk about what the alternatives are. And if there is a history of cardiovascular disease or risk factors, there are specific agents that are recommended above others.
Yeah, I think the SGLT2s and GLP-1s in particular are starting to emerge particular cardiovascular benefits. So we're talking with Associate Professor Ralph Audham, a Melbourne GP, who's part of the diabetes update for the therapeutic guidelines. Sliding down to the bottom of the scale now, Ralph, the updates look long and hard at hypoglycemia, and this is usually iatrogenic in one way or another. What's important about the new hypoglycemia management?
What I like about these guidelines, which may interest a lot of GPs and even some of the GPs who manage people within hospitals, is the use of glucagon, but also what we call mini-dose glucagon. So within adolescents or children who may be coming low, you can actually give them smaller doses of glucagon to avoid an impending hypo if they're not actually eating very well.
Okay, so the smaller doses of glucagon, you titrate part of a larger dose, or it comes as its own smaller?
Yeah, no, you have to actually draw it up within a syringe itself. It's a nice little an equation to use. So, within that 3 to 15 years, they have, 1 unit per year of age up to 15 units, which is a nice, easy way to remember what dose you should be using.
Excellent. There's also, I see, a new section on glucose management in adults with type 2 diabetes who are hospitalised. As a GP, hospital management is always a bit of a black box to me, but I guess someone's got to do it. So it's nice to see those guidelines there.
I think this is a really powerful part of the book. One of the things that we do stress is that for managing people with hyperglycemia within a hospital, you always follow the local guidelines that you have. But if you're a GP working remotely and you are the GP for the local hospital and they may or may not have local guidelines, there are suggested things that you can actually do while you're getting either further advice or transferring the patient to a larger centre.
Excellent. I can imagine that being very useful indeed. Ralph, we're seeing a technological revolution in measuring and dealing with blood sugars for people with type 1 diabetes. There's flash glucose monitoring, continuous glucose monitoring, and even do-it-yourself looping connected via smartphones and watches to insulin pumps. So I see you've got a bit of an introduction to these things in the guidelines as well.
I mean, this revolution that you're talking about is absolutely fantastic. And not only for type 1, I mean, the continuous blood glucose or the flash glucose monitoring is new technology where basically you can actually have continuous blood glucose readings without them having to prick their finger. And it gives a wonderful representation of what happens through a whole day. And, many of these will last for up to a week or 2 weeks. And what we're finding is that when you look at the tracing like that, you can often see where the burden of hyperglycemia or even hypoglycemia is happening. And then you can specifically target those areas. Patients actually feel really liberated on it because they get a large amount of information and they're not having to do that, pricking the figure, 4 or 6 times in a day when you're trying to work out what's going on. The only issue is it is actually measuring glucose within the interstitial fluid. If there is a little bit of a lag between what's happening within the serum, glucose is dropping very rapidly and they're having a hypo. The actual, flash glucose monitoring or the continuous blood glucose may not have caught up with it and still say that their sugar's okay, even though they're having a hypo. So they still need to check by finger prick or treat, if they're having experiences of hypo.
Thank you. And I think feedback I've had from people with type 1 diabetes who are certainly the main initial users is that it not only helps keep them in range, but it just helps their daily life, helps them have to think less about their diabetes throughout the day. I see there's also new advice about women who already have type 2 diabetes and then fall pregnant.
Yes, I think this is a really important topic. We are seeing a lot more women with type 2 diabetes now conceiving and having children. Type 2 diabetes is predominantly managed within general practice. And so as GPs, we do need to be aware of women who have type 2 diabetes. In fact, all women with diabetes that we look after, we need to find out whether they are planning to have children in the near future, because improving their control prior to conception is really, really important, involving that multidisciplinary team. And I'll often refer women who are planning a pregnancy, to an endocrinologist with an interest in diabetes in pregnancy prior to them getting pregnant. So everything's actually in place when they decide to have a baby.
Look, thank you very much, Associate Professor Ralph Ordem. It's been a pleasure talking to you, and people can find all this information, of course, in the Australian Therapeutic Guidelines, known to most of us as eTG, because that's how we access it on our computers. So thanks very much for spending the time today explaining it.
You're welcome.
The guest's views are his own, not NPS's, and I just make up things as I go. Ralph declares there's a conflict of interest. He's participated in advisory boards for AstraZeneca and Novo Nordisk. I'm Dr. Justin Coleman. Thanks for listening to another Australian Prescriber podcast.